that's sociologically. We're circuited so that we notice the negative, because the negative may be a wildebeest coming to get attacked by a lion. So, but what the patient comes into treatment with in terms of their expectation influences how well they do. Actually, Woody Allen said, pessimists have a more realistic view of life, but optimists live longer. So we encourage optimism in our patients. I do a lot of hand-holding and encouragement. And it turns out the number one variable in our patients with chronic pain and substance use that correlates with good outcome is self-efficacy. People familiar with external locus of control, internal locus of control, people who move from I'm the victim, you got to help me, get me a massage, move my body, put a needle in me with acupuncture, move from that stance to I got this, I can take care of this, I have tools and techniques that will help my life be better. Those patients do much better than the ones who don't. Okay, so the process of acute pain becoming chronic pain changes from transient activation, broken ankle, alarm clock ringing, to this sustained current, and that just is a buzzing alarm clock, I'm already awake. So it's maladaptive, malfunctional pain. I mentioned my shoulder, I also have chronic low back pain. I have a bulging disc at L4-5, and I love talking about it. I'm not going to do a lot of it, but, so the sustained activation comes from the disc, but really it's what happens inside my brain and the structural remodeling because of our ability, our plasticity of our brain that causes pain. And this is a reverberating circuit that involves a whole lot of complex functions. An increase, an enhancement of the signal because the brain thinks it's important that we feel the pain, even though I can tell you my back pain is dysfunctional. I don't need it for anything. It doesn't keep me from doing anything except standing on my head, but that's mostly because I get dizzy when I stand on my head. But I mean, I can hike, I can climb, I can lift. But it's irritating and annoying and frustrating, and that frustration is happening inside our limbic system, inside the emotional part of the brain, and the worse my feelings about the pain, the more afraid I am, the more anxious I am, the more angry I am, the more frustrated I am, the worse my pain gets. And those latter four phenomena are things that we can deal with in an addiction treatment setting, in a therapeutic environment, not so much in the medical setting, unfortunately. So I mentioned brain changes. There's actually atrophy of significant numbers of brain areas. This is a normal, robust, active brain scan, and you can see that the particular areas, the thalamus, there's almost no signal in the thalamus. There's a change in the way the brain processes the pain signal. Another thing, or last physiological thing about the pain system is that nociception is the sensory experience of pain. Pain is that overall experience that includes the emotions that I've been describing. And it turns out that some people feel more pain than others. Does that sound believable to you? We call them sensitive and appropriately concerning. The reason for the nociceptive interpretation is related to an enzyme system called COMT. COMT is catechol-O-methyltransferase. You can say that 4 times fast. The COMT metabolizes neurotransmitters in our brain, including dopamine, which helps us with a sense of well-being, and noradrenaline, norepinephrine. So the excitation neurotransmitters are metabolized differently depending on which version of COMT you have. Does that make sense? Let me get a little more specific. Let's say Ben here has a version of COMT that makes the pain go from a very light experience to a huge emotional distress. So that means I go up to Ben and I poke him this hard enough to blanch my fingernail, pretty light. Ben, in this example, would start to yell, "Oh my God, what are you doing? You're killing me. Oh, please get away, no more, no more, no more." Now, what would we say about Ben? Don't be nice. Hysterical is a scientific diagnosis. What else would we say? Big baby, wuss, right? There's others, but we're in Great Britain, so people are polite. But we would judge this poor guy, would we not? We do judge people who manifest a sensitivity to a painful signal. And you're Jaime, I poke Jaime, Jaime goes, dude, don't poke me. And we're all, oh, you know, tough guy, wuss. You know, we've established that. And I just got through telling you that there's an enzymatic difference causing this sensitivity. Let's look at behind the enzymatic difference. The first is genetics. 50% of the explanation of pain sensitivity is in the genetics. So it's not uncommon to see a patient with a parent who's had a chronic pain syndrome and a kid who comes home from school with growing pains, and nobody understands why. The second phenomenon that we've talked about quite a bit last night with Dr. Black is trauma. People who have been traumatized have a heightened sensitivity to pain. It's like the volume knob inside the central nervous system is turned up. Now that shouldn't surprise us, but the physiology of the change in the COMT system has been scientifically proven to be responsible for the increased sensitivity to pain. And I'm talking about childhood sexual trauma, witnessing horrific events, you know, any number of physical and emotional traumas, but I'm also talking about a phenomenon that we call medical trauma. People who've gone to the doctor, had all the tests I described, had surgery, failed surgery, go to another surgeon, and the surgeon operates on the level above and the level below, you know, 2, 3 fusions, and then they get an infection in their spine and they're in the ICU on an IV antibiotic for 3 months. That is traumatizing behavior in the medical, thanks to the medical system. And a lot of our patients come in with that kind of a history. So the normal pain response, just take a look at the slide for 1 minute. The normal pain response looks like that. A variety of areas light up with a certain magnitude. Central sensitization, or this pain syndrome where people feel more pain than makes sense than they should, because this shouldn't cause pain, have a brain that looks like that. Central sensitization. And that's the explanation. The syndrome, if Ben was sensitive all over his body, on both sides of his body, upper and lower, do you know what that's called? That's fibromyalgia. There's a lot of my colleagues that think fibromyalgia is a bunch of BS. This is the brain of somebody with fibromyalgia. I poke them and they experience pain because the volume knob is turned up inside their limbic system. And of course, what makes that worse is anxiety, anger, and fear. Interstitial cystitis, chronic headaches, complex regional pain syndrome are all forms of central sensitization. Not well understood by our medical culture. So not everybody with chronic pain is in trouble with their chronic pain. There are people that walk and talk and manage and function and work and laugh and sleep. But people that we see in our program are people with chronic pain syndrome. So it's this long-term pain, but it's also depression, anxiety, anger, and fear, restriction in the daily function and activities, excessive use of medications and medical services, and it might be addiction or it might not, multiple non-productive tests, treatments and surgeries, and no clear relationship to the organic disorder. So that's that chronic misunderstanding that people are subject to and misinterpretation. So here's the problem with pain. How do we know how much pain you're in? We ask you, and it's whatever you say it is the truth, unless we can prove it otherwise. Well, there's absolutely no way in our common medical system or social system to say that your 10 is not a 10. Ben, in this example, he's always going to be a 10. He's going to be whining. He's going to be 15, 20, right, out of 10. There is a functional MRI system where we can put people in a machine, but it's really only at Stanford University in California and Northwestern University and several other sites in the States and in Europe, where they can calibrate in the brain what's happening in the brain. Even that, however, is not an accurate reflection of your subjective experience of pain. Pain is a subjective experience. We have to pay attention to what the patient says. So what about treating pain? Really, where we want to function, where we want to pay our attention to is function. So maintaining and preferably improving function and reducing discomfort by 50%. And those are our treatment plan goals at the center in Las Vegas. Essentially, pain is the secondary goal, but pain always decreases. 90% of our patients achieve those goals with the treatment that we offer. And as I'll explain, one of the treatments is to take away the opioids. We can use non-opioid medications to treat pain. The NSAIDs, people familiar with that? The non-steroidal anti-inflammatories, ibuprofen, aspirin, diclofenac, which in the States is Voltaren, naproxen or naproxen. I mean, there's probably 20 different ones. They work on prostaglandins, which is in the peripheral part of the nerve and not in the central part of the brain. I had a patient who was typical patient. He was on methadone 160 milligrams a day, Valium 60 milligrams a day, Ambien 20 milligrams at night, and Adderall 40 milligrams a day for tiredness, not even for ADHD. and we detoxed him. We took him off every single one of those meds. And 2 years later, he's clean, he's sober, he's going to NA and AA meetings, has a sponsor, sponsors people, and he calls me up. He says, "Doc, I'm getting my wisdom teeth pulled. I'm really petrified. What should I do for the pain?" And I said, "Well, check with the dentist, but if he says it's okay, ibuprofen, 600 or 800 milligrams is an effective dose." He called me up the next day, said, that ibuprofen. All it did was take the pain away. If you're looking for an opioid effect, you will be disappointed with the effect of ibuprofen. And that's what happens to my patients. They tell me ibuprofen is crap. When they're detoxed and we offer them 400 milligrams of ibuprofen, they say, "Wow, you know, my shoulder, my knee, my back doesn't throb quite so much for about 3 or 4 hours." And it's equipotent. 600 milligrams ibuprofen is the same effect on pain as a 5 to 7.5 milligrams of hydrocodone. But the ibuprofen doesn't do anything for the anxiety, the anger, the fear. You know, it doesn't. I had a patient say, "Well, you know, I get along better with my wife when I take my hydrocodone. Is that a problem?" You know. Antidepressants, so the tricyclic variety, are sedating. That's amitriptyline and nortriptyline. Sedation is a good side effect because sleep is always impaired with people with chronic pain. So anything we can do to help them sleep without habituating substances is positive. SNRIs are the serotonin norepinephrine reuptake inhibitors. So duloxetine, you have those in Europe, yeah? Or venlafaxine. Those work on the body's own intrinsic pain inhibiting circuits. So that's norepinephrine and serotonin inhibit pain. In particular, antidepressants work better than others. But Cymbalta in the States, or duloxetine, is pretty effective for the central pain syndromes. Anticonvulsants are a little controversial. So we're talking about gabapentin or pregabalin. The controversial because in the States we're seeing abuse. In Europe, are you seeing abuse of Neurontin, gabapentin? So we can't use them without some concern. They work on the GABA system, which is the same place that the benzos work, but they're not the same potency and they're not the same efficacy, and they do work for neuropathic pain. So they're up for consideration, but with care. Muscle relaxants, Soma is off the market here, isn't it? Carazoprodol? I believe it's off the market in Europe. It's a terrible, you don't know because it's off the market. It's on the market in fact, in Las Vegas, Soma hydrocodone is the Las Vegas cocktail. It's a horrible brain relaxant that's very dependence-inducing. So it's much like a benzodiazepine. Other muscle relaxants, they're not terribly effective for pain, you know, plus-minus effectiveness, but tizanidine and Lioracet and some other ones have some efficacy against pain. And then finally, topicals, things that are in patches or gels or creams, can be effective for a mild pain relief. So you can put ibuprofen in a gel or diclofenac in a patch and put that on and end up with a decrease in pain. Capsaicin is a chili extract and causes a burning sensation, and burning inhibits the pain signal. So if you have a burning sensation and you don't mind the burning sensation, then that's a good effective intervention. Those are all prescription in the States, but you know, patients say, "Oh, you know, maybe it helps a little bit." Well, we're working around the edges of the pain. We're not taking an opioid and clobbering the pain on the head. We're working around the edges. That's our goal with chronic pain treatment. And you know, you get 5% with a lidocaine patch, for example, and another 5% with an anti-inflammatory, and 5% with a stretch, and 5% with a walk, and 5% with a prayer, and 5% with a positive affirmation, and you're down 30, 40%. And that's pain treatment. Not to mention you have the breath and meditative practice. So what do we do with non-malignant pain in the States? If it hurts, we use ibuprofen at first. If it hurts a lot, we start up with the opioids and hydrocodone's as good as any. If it really hurts, we give oxycodone, which is 10 times the strength of hydrocodone. If it still really hurts, let's look at this logical step. We give more oxycodone, and usually we'll add long-acting to short-acting products. If it really hurts for a long time, then we get really scientific. We keep giving more. If it gets worse, no matter what I prescribe, I discharge the patient. There's something wrong with that formula, but that has been up till now, up till recently, the formula. I can give you medication, it will work. The question is what's going to happen over the course of time. So what's the logical approach to treat chronic pain with opioids? We ought to do it as a clinical trial. Let's see if it works. Well, in the short run, unless you're allergic, it'll work. If you have back pain, whether you have addiction or not, if I give you enough hydrocodone, you will get relief of your back pain, and it'll probably be very little amount that it'll take. That's good news. The assessment on that next visit will be everything is fine. Go with God. If I refill the prescription, however, and you come back and the prescription is run out in 3 weeks instead of 4 weeks, that's the choice point. Should I double the dose or increase the potency, or should I really say, this is a failed clinical trial, let's turn to something else? As I suspected, this is not a good plan. Unfortunately, that's not what we do. So the CDC, because of this opioid explosion of prescriptions, the CDC's come out with guidelines in the states I mentioned, and their response to whether you should ever use opioids for chronic pain is, it's not never, it's not always, it really depends. It depends on a lot of things. And they go on and say it should always be part of a comprehensive management program based on assessment, trust, relationship, and verification. In other words, patients doing what he or she says they're doing. Conscientious, judicious use, balancing risks and benefits, informed consent and agreement, communicate and connect, assess all the time the 5 A's: pain relief, analgesia, ADLs, function, adverse side effects, aberrant behavior. Are they going to multiple pharmacies for the same prescription? Are they running out early? Are they consulting with other doctors? And are they developing addiction? Those should, at each visit, should be a source of discussion. 2 of the CDC guidelines I want to point out. One is they recommended staying under 50 milligrams of morphine equivalent a day. That's a pretty hefty dose. That's 4 or 5 hydrocodone a day. They said increasing beyond 90 should be done very carefully. Now, the pushback against that is you won't let us prescribe more than 90 milliequivalents. Well, that is the guideline. It doesn't say you can't. It says be judicious. Why? Because this graph shows that if you're on 50, you have 3 times the risk of overdose. If you're on greater than 100, you have 11 times the risk of overdose. It's a simple formula. So staying low, and I should tell you that benzodiazepines in combination with opioids exacerbate the risk. The second guideline is really controversial, but it's really, the data behind it's real interesting. It's the 3 to 7 day guideline. They tell us that long-term opioid use often begins with the treatment of acute pain. So they recommended lowest effective dose of immediate release opioids. 3 days or less will often be sufficient. And we've got studies that prove that. Most people who get a 30-day supply of a prescription don't use most of that prescription. And you know where it ends up? In their medicine cabinet. And you know who's accessing that? Their kids. The #1 source of opioids for kids. More than 7 days rarely needed. Well, this one is hotly debated. You're under-treating my pain. The reason for this guideline is that the longer you use opioids, the greater the risks, and the risks seem to rise fast. I think this is staggering. So this shows us that if you're on an opioid for 10 days, the probability of being on them at a year is 21%. 10 days, 21% on a year. And if you stay on them 30 days, there's a 22% risk that you'll be on them at 3 years. So this is where it's starting, folks. I'll tell you a quick story. There's 3 men sitting on the side of a river, and they're watching. It's a beautiful day. The river's going into a waterfalls. The steam is rising from the waterfalls. All of a sudden, they're looking at the river, and there's a baby in the river bobbing up and down. And then there's another baby, and another baby, and another baby, till the river is filled with these babies heading towards the waterfall. Well, the first guy jumps into the water and starts gathering up babies and bringing them onto the side of the stream. The second person goes into the forest and gathers up logs and ties them together with vines to make a raft to gather up as many babies as he can. The third one runs away. Now, where do you suppose he went? He went upriver to find out who's throwing in the darn babies. Who's throwing in the darn babies is doctors prescribing tons of pills for acute situations. So this is my prescription after a small surgical procedure, and I received, when I awoke from the anesthesia, 50 10-milligram Percocet in a prescription. And I had told the doctor that I did not want opiates because I was a man in long-term recovery. She said, I won't give you many, and I won't give you anything strong. Now, if I was an uneducated consumer and I took that medicine for 10 days, there's a 21% likelihood I'd be on them at a year. That's who's throwing in the babies. So, and those doctors are getting educated, thankfully. There's a lot of problems with opioids. Side effects are problematic. The worst side effect of opioid, anybody? Anybody know? Constipation. You know, respiratory depression, of course, but constipation is the biggest problem. We had a patient admitted to the center. She was a maid. She injured her back. She was on 60 to 80 milligrams of hydrocodone a day. She was 80 pounds soaking wet. And she had such bad constipation, the only way she could move her bowels was that she had to manually disimpact herself every 10 days. That means put her hand up her butt and pull out the stool. She was suicidal. Not a benign condition. But there's good news in the States, at least. We have a course on opiate-induced constipation at every pain conference, and we have drugs that treat it. And then we have a name for it. We call it pain-stipation. I mean, that is the American way. The other problems are respiratory problems. So respiratory depression, sleep apnea, hormonal problems, low testosterone and low estrogen causing decreased bone density, problems with the immune system. So these are not safe, benign drugs, and we always ought to be measuring risk versus benefits. Tolerance and dependence happen with all opioid medications in every single patient. People function less, and they treat their emotional pain, they treat their physical pain, which they experience as emotional pain. It's called chemical coping, so that's hydrocodone for my anxiety, for example. And finally, there's a phenomenon called opiate-induced hyperalgesia. That means more pain on the opioids than off the opioids. It turns out opioids inflame the brain. Opioids cause more pain. I'll say it again. It's crazy. Opioids cause more pain. I mentioned that woman who had chronic headaches, and she came into my office. She was angry at me. She looked up on my bookshelf and she said, I want to borrow that book, Medication for the Treatment of Chronic Pain. And I said, you're welcome to borrow the book. That book says Meditation for the Treatment of Chronic Pain. Opiate-induced hyperalgesia looks like this. We get to the optimal dose of opioid. If we increase the dose of opioid, we will have more pain. The only thing to do about that is to lower the dose. And in our program, we take people off the opioid. And I can tell you, just stopping the opioid within a week or two causes pain levels to go down. It's staggeringly, it's just unbelievable. So this opioid deal is a pendulum that swung. You know, it was opioids for everybody, opioids for nobody. And in the turn of the century, it was heroin for aspirin needers. You know, that's Bayer made heroin in a bottle. And then in the 1920s, we realized that opioids were causing dependence and addiction, and people were overdosing, and they were using heroin. So they passed the Harrison Narcotic Act in the United States that made it illegal for a doctor to prescribe opioids to anybody who had addiction. And then things shifted in the 50s. The hospice movement actually started in Great Britain, very smartly said, if people are dying, let's relieve their pain as best we can. And they did, with very high doses of opioids. Turns out opioids in one study really work about maybe 20 or 30% of the time with moderate relief. But let's give what we need to people who have a short lifespan. And then, at least in the States, and you know, this is international, but the pharmaceutical companies sat around a table, I believe, and they said, well, you know, there's 30 million people dying of cancer in the United States, and their average lifespan is 90 days, so that's not much of a market. So let's expand our market. How can we? Well, we've got 50 to 100 million Americans who have chronic pain, and they're going to be alive for decades. And that is our market, and that was their market, ladies and gentlemen. The greatest offender was Oxycontin, a long-acting version of oxycodone, came out by Purdue Pharma. Purdue, you may know, was fined for falsifying their data. $600 million. Do you know what you call that to a company like Purdue Pharma? Chump change. The cost of doing business. And in the states today, there are countless lawsuits from states and municipalities and attorney generals against pharmaceutical companies. So I think it's going to be a movement like against big tobacco. But in these days, they told us that this pill was slow acting, it couldn't be addictive, but it turns out you can just crush that pill and snort it up or inject it or smoke it, and it's quite addictive. So you know what they did in response to that? They made crush-proof Oxycontin in 2012. Turns out my patients tell me that you can freeze it and microwave it, crush it up, and it works just fine. And we have Opana ER, which is easily crushed. So we can't legislate around it. But we are in an epidemic, certainly in terms of the numbers. The first set of slides is about treatment for non-heroin opioids. And just look at the red states in the United States, starting from 1999. Red is the high incidence of admissions, greater than 45 per 100,000. And just look what happens in 10 years. And this is just in the United States. So that's the trend in treatment. And what we found is that the need for treatment correlates with the death rate. So I'll show you another slide that shows the rates, but 42,000 deaths in 2016 from opioids. And as the death rate rises, the treatment rate rises, opiate sales have risen. So I'm going to rail just one more time against the pharmaceutical industry and say that they had a concerted effort. You know, how did this happen? The docs in the United States were told a bunch of lies. The first lie, or the first influencing statement, was, you're needlessly allowing patients to suffer because you're opioid-phobic. That's your problem, doctor. Loosen up your prescribing practices. The next lie they told us was opiates are safe and effective for chronic pain. How many studies do you think they had to prove that? None. They had studies on cancer patients whose average use was 90 days. Then they said that opiate therapy can be easily discontinued if you're taking them for pain. Right? Why would that be true? It doesn't make any sense. They told us that. We believed that. And then the final thing was opiate addiction is rare in pain patients. Now, that is the most specious comment that's ever been told to the general public and to the physician-educated public, but we believed it. This one was study-based. So here's what they said. Porter and Jick, addiction rare in pain patients treated with narcotics. Now that's the New England Journal of Medicine. That's a pretty prestigious journal. Would you like to see that study? That's it. It was a letter to the editor of the New England Journal, and I'll just summarize it for you because you can't read the writing. 40,000 charts retrospectively reviewed in a hospital. 11,882 patients got 1 dose of opioid. Then they went into the chart and looked for the word addiction. It was only there 4 times. That was the essence of their study. You know, crazy and bogus from the beginning, but this really set things off. The rest of the story is they advertised that these drugs were good for function. You know, Oxycontin for pain lasting several days, weeks, months, or more. No ceiling, no limit. They said freedom from pain, and the FDA allowed it. So our government oversight was complicit in this epidemic. And then finally, we have an organization called the Joint Commission on Accreditation of Hospitals who tells us what to do in order to be certified to do what we do, and they created a 5th vital sign. You know, we check blood pressure, pulse, temperature, and respiratory rate, and then they mandate in every shift in every hospital and clinic in the United States that you check the pain score, subjective pain score. Now, what's a nurse going to do if she has 12 patients that she's responsible for on a medical floor in a hospital and the pain is 6? She's going to medicate because that order's already been written. So what's happened in the States, and I believe it's happened all over the world, is that as it's gotten harder to get prescription drugs, people have been introduced to the opioid, and now they're moving to heroin. So the second wave of this epidemic is deaths from heroin. And in the United States, that's quite prevalent. And then the third, which I think is catching up in Europe as well as home in the States, is synthetics, primarily fentanyl and sufentanil. These are products that are being synthesized in laboratories, primarily in Asia. They're being imported in the States, and the cartels are distributing them high, 1,000 times the potency of heroin. So people are taking the drug, inadvertently overdosing and dying. I think it's 20,000 deaths in 2016 and 30,000 deaths in 2017, and it's rising. This is not, we haven't hit the end of that curve. So what do we do? Well, in one of the treatments of opiate use disorder are to substitute a safer opioid. Methadone would be one. In the States, you have to be administered in a clinic. Long-acting drug, not as much of the peaks and valleys as, for example, morphine or heroin, associated from a data standpoint with decreased criminality, decreased infectious diseases, decreased IV use. In the States, we've gone with buprenorphine. You got a lot of buprenorphine over here in Europe. Suboxone is the main brand name in the States. A partial agonist of the opioid receptor, that means it doesn't get you quite as high. At least we're told it doesn't, except for the kids who come into my clinic and say, oh, that's my drug of choice, doc. I love Suboxone. But for the most part, Suboxone is a better, more stable drug than certainly heroin. People don't overdose on Suboxone. It stabilizes the brain. My concern about the use of Suboxone and methadone is there an exit strategy? Or are we in this for life? Are we putting an 18-year-old opiate addict on Suboxone, and that's where he or she is going to live his or her life? And there is cerebral effects from this medication. It's not a benign substance, and it is an opioid. And you know who's producing Suboxone in the United States now? Purdue Pharma. Right. Just enough to make, I wrote myself a note. There was a newspaper article, and I filed it under the balls of Purdue Pharma. They created the drug, they created the crisis, people are addicted, and now they created the drug to treat the addiction. They're making money on all of it. Now, Trexone is a blocker, comes in the States. I'm not sure what it's called here, but it's an oral form, Revia, or an injectable form, Vivitrol, blocks the opioid receptor, so if you're on it, you can't get high. And naloxone, of course, is Narcan, the drug reversal blocker, so it reverses an overdose. My time is growing short, so I want to stop for a minute or two and see if people have burning questions, and then we'll come back. Yes, sir?
What about cannabinoids?
A short question. Cannabinoids. Well, I'll tell you, I have the U.S. version. In the United States, we have what's called medical marijuana. Marijuana as medicine. It turns out there is no such thing. There's legislated marijuana. A bunch of states voted to make marijuana legal as medicine. We don't have any supervision of the production or synthesis, so the unreliability of what's in the substance is what concerns me. The two key components are THC, the intoxicating component of cannabinoids, and cannabidiol, which is possibly therapeutic for a lot of conditions, including pain. In the States, it is marketed that the CBD has to have THC in it to be effective. So pure CBD is hard to find. There was a study that said 60% of the labeling on a CBD product was inaccurate. So the long and the short of it is, I don't think it's as good as the cannabinoid industry would tell us that it is. It's a big industry in the United States. I think it is in Europe as well. But it may have an effect. If people want to try a CBD product on their skin, an oil or a cream, I have no heartburn about that. But using CBD ingestible makes me nervous, especially because it may contain THC. So, good question. And again, the efficacy studies don't say it works terribly well. Other question? Okay. Yes?
Can I make a comment? I ran a treatment centre for 30 years here at the NHS, and in 92, 93, 94, 95, the Eurocountry people ran methadone maintenance clinics and huge conferences, 4 times the size of this,
Yes.
where everybody was encouraged to consider the use of methadone for long-term opioid users as a way of getting them into some sort of stability place where they could then be reduced by. I think it's important to remember that for us to note that a lot of our patients convert their symptoms into pain.
Yeah.
If they can't get their opioid. And whether we like it or not, if you take the opioid away, the pain comes back. And we can say it's real, like you say, it is real.
Yeah.
But maybe there's still a place for us to think that these guys are going to go back on heroin, as they are, and you showed us the graph.
Yeah.
that we should relook at some of the papers from 95.
Well, I think, yeah.
Think of a period of controlled maintenance.
Yeah.
Whereby they can get some better treatment.
Yes. So
Not have to be put back on the streets.
two comments. One is methadone is one of the worst drugs for hyperalgesia. In fact, opioid-induced hyperalgesia was discovered by a nurse who worked in a methadone clinic where people's wouldn't let them take their blood because they had excruciating pain when they poked them with a needle. And she got real interested in that. And so that's one resistance or concern about being on methadone for pain. Long term, it's not the best pain reliever. Buprenorphine's a different substance and has some good potential use for chronic pain. We even use it in our clinic for people who are recalcitrant. They just can't get out of pain. My experience is it doesn't work that well. And the last thing I'll say about your comment is that for people with pain, craving is pain. Pain is craving. So, and the pain syndrome, the pain circuit and the addiction circuit, the salient circuit are irreversibly linked, inextricably linked. So you can't tell the difference. And I would agree with you that somebody being alive is good, somebody being on a maintenance medication like buprenorphine or methadone is better than being on heroin. I just don't know that it's the best solution in the long run, and I don't know how we get from there to there. That's my concern about it, but thank you for the question. So what's the difference between being addicted to painkillers and just really, really liking them a lot? You know, the drug companies really blamed this epidemic on those addicts, when in fact we see a bunch of people who have dependence and they are pathologically pursuing not reward but relief. It's the pursuit of relief that gets people into trouble with the opioids. And that, by the way, is a definition from the American Society of Addiction Medicine. So the differentiation between pain patients and drug abusers is a specious one. And I'm going to skip this just so I can get to the treatment. I talked about non-opioid medications. Motion is lotion. People are kinesiophobic, they're inactive, and as a result, they don't move, and movement is the solution to that. So getting people moving is a big part of our program. Weight loss is important. Diet is important. Sugar is the most inflammatory substance around. Nicotine is extremely inflammatory. Behavioral treatment is key. I don't have time to talk in detail, but CBT, DBT, ACT, mindfulness practice, awareness and attentiveness to the moment. There's great data studies on mindfulness for pain. John Kabat-Zinn is the best expert in that. And this is just a list of the treatments that we do at our center. And really key is mindfulness and individual and group therapy. And we get people moving in physical therapy, but also in yoga and qigong. And you may know this, research shows that actually drugs give the same benefit as yoga. So if you're a yoga practitioner, you might be able to short circuit. And this is the halasana pose for back pain and insomnia. You can see the drug is working pretty well. Child's pose, I can't get my knees down either. And then the savasana pose, the drug is working perfectly well. That's my favorite and most effective pose. And I'm going to I think we're done with time, so I won't answer any questions. And thank you very much.